Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a case of medulloblastoma, SHH-activated TP53-mutant, and how we can reach to this diagnosis actually utilizing only immunohistochemistry. So this is a case of a 13-year-old female patient with cerebellar hemispheric mass, and as you can see, this is a small round blue cell tumor. It's an embryonal tumor, but showing severe diffuse anaplasia. With what are the features of anaplasia? We have cell-to-cell wrapping here, and here we have enlarged cell size. And remember, the large cell in medulloblastoma, we have to look for a reference, and our reference would be a red blood cell, and the tumor cell should be 3 times or more than the size of a red blood cell. And as you can see here, for example, it's at least 5 times the size of the red blood cell, more or the same here, really large, ugly cells, as well as large number of mitotic figures that are easily identified. And then we see apoptosis. And another important clue for the large cell anaplastic medulloblastoma is, in addition to the mitosis, the presence of a large number of apoptotic bodies, sometimes forming microabscesses. So the presence of a microabscess of apoptotic bodies is excellent clue that we're talking about or dealing with large cell anaplastic medulloblastoma. So once we're into the embryonal tumor, probably large cell anaplastic medulloblastoma, how can we then sort out the subgroup of medulloblastoma using immunohistochemistry? And the first, of course, is synaptophysin. And with synaptophysin, as you can see, there is this very peculiar dot-like cytoplasmic staining, which is typical of, especially when it's diffuse, of large cell anaplastic medulloblastoma. But this should not really be evaluated separate from the morphology. So this has really to be coupled with the morphology in order to make a use of this feature of dot-like cytoplasmic staining of synaptophysin. And then Filamin-A cytoplasmic staining that is diffuse, seen in the tumor cells. And so we're talking, once we have Filamin-A positive, we're talking about either the Wnt-activated medulloblastoma or the SHH-activated medulloblastoma. Group 3 and 4 usually are negative for Filamin-A. So the next step would be beta-catenin. And remember, and I have a video on how really to interpret beta-catenin. Beta-catenin should, for the mutant beta-catenin, we should see in nuclear staining. If we're not sure, go on oil immersion and look for the nuclear positivity, and the issue will be solved. So in this case, all the nuclei are negative. There is no evidence of a nuclear staining. So a simple equation: filament positive, beta-catenin, nuclear stain is negative. This is equivalent to SHH-activated medulloblastoma. Once we have this diagnosis, we should now do P53. And P53, there is an excellent concordance between P53 immunohistochemistry and the mutation status of P53. So once we have P53 strong nuclear staining in 80% or more of a tumor cell in nuclei, we're almost sure that this is a mutant. And given the context of an SHH-activated medulloblastoma, this would be consistent with TP53-mutant medulloblastoma. We always do reticulin stain just to make sure that there is no desmoplasia and nodularity. Remember that most cases of SHH-activated medulloblastoma are desmoplastic nodular, but not all cases. So all cases of desmoplastic nodular medulloblastomas are SHH activated, but not all SHH activated medulloblastomas should show a desmoplastic nodularity, because as in this example, we have the anaplastic large cell variant or subtype of medulloblastoma. I have to allude here to the important role of radiology in confirming really the or supporting the diagnosis, because by radiology, actually a good radiology image with a good radiologist with interest in neurology can really suggest the subgroup of medulloblastoma, because SHH activated medulloblastomas usually are solid masses with the epicenter present in the cerebellar hemisphere. It's not in the vermis, it's not in the midline, it's not in the fourth ventricle, and very characteristically it shows heterogeneous intense contrast enhancement. So put together, if we just sum up the case, the radiology is suggestive of SHH activated medulloblastoma. The morphology is large cell anaplastic, that showing dot-like cytoplasmic positivity with synaptophysin, immunohistochemistry, Filamin-A positive, Beta-catenin negative nuclear stain would really be consistent with SHH activated medulloblastoma, and then the strong diffuse nuclear staining with P53 would support the presence of the TP53 mutation, and reticulin is negative. So the final diagnosis in this case is medulloblastoma, large cell anaplastic variant, suggestive of SHH activated TP53 mutant medulloblastoma. So morphology is important, immunohistochemistry is important, especially if you're reporting in neuro-oncology. You have to acquire these three stains, beta-catenin, and you have to know how to interpret it. Filamin-A, it's really a robust immunohistochemistry that can be easily produced at your lab, and then the P53 immunohistochemistry. Put together, you can, with confidence, really subgroup medulloblastoma based on immunohistochemistry. Always remember to integrate the diagnosis with radiology, because there is a good really correlation between molecular subgroup and radiological findings. I hope you find this tip useful in your daily practice. Thank you.